Hello, and welcome to Ask the Doc. This is our monthly program where we invite our audience to ask questions of our experts in Alzheimer's disease and dementia. UCI Mind is part of a network of nationally designated Alzheimer's disease research centers funded by the National Institute on Aging, which is part of the National Institutes of Health. My name is Dr. Megan Whitbrock, and I'm the Associate Director of Education here at UCI Mind, and I'm your host for this program. Today, I'd like to welcome back to the show Dr. Joshua Grill. He is the Director of UCI Mind and a Professor of Neurobiology and Behavior and Psychiatry and Behavior here at UC Irvine. Dr. Grill received his PhD in neuroscience from the Wake Forest School of Medicine, and after an 8-year tenure at UCLA, directing an Alzheimer's disease clinical trials program, he was recruited to UCI Mind. Dr. Grill's research interests include understanding ways to improve Alzheimer's disease clinical trial design and examining barriers to trial enrollment. Welcome, Dr. Grill.
Thank you, Megan, and Happy New Year to all of our viewers and all of our community. It's great to see everyone, or I guess let everyone see us here in 2022.
Absolutely. And I'd like to welcome our viewers as well. If you have comments or questions, please include them in the comment box in the Facebook or YouTube program. So with that, let's get started. Dr. Grill, back in June of 2021, the FDA granted accelerated approval to Biogen's Alzheimer's drug, Aducanumab. Can you talk about Aducanumab and kind of bring us up to date to where we are now?
Yeah, of course. And, clearly it's a really important topic on many levels. I think it's probably makes sense to spend just a little bit of time going back to the beginning and seeing what Aducanumab is. Aducanumab, or its brand name now is Aduhelm, is, as you say, a treatment for Alzheimer's disease. Specifically, it's a treatment that targets one of the most well understood, well described things that happens in the brain of a person with Alzheimer's disease, the accumulation of an abnormal protein that we call amyloid in what we call plaques, or amyloid plaques or neuritic plaques. And essentially every person who has Alzheimer's disease gets these amyloid plaques in the brain. And for years and years, we've known that this is very important. There's tremendous evidence to support the role of amyloid as critical in progression, the onset, the risk for getting Alzheimer's disease, dementia, and cognitive decline. Aducanumab is a treatment that directly targets that amyloid protein that accumulates in these plaques in the brain of a person with Alzheimer's disease. And it's a potent one. It has been shown in multiple clinical trials to actually reduce the amounts of plaques in the brain, which we can measure through PET imaging. That's very well demonstrated at this point. What's a little less well demonstrated is whether lowering amyloid plaques in the brain is enough to actually slow the progression of Alzheimer's disease. So of course, Alzheimer's disease is an unrelenting progressive disorder. Over time, while people may get worse at different rates, essentially everyone gets worse. And this is a fatal disease that ultimately will make people completely dependent on others for their care. So we know that Aducanumab and now other drugs like it can lower the levels of amyloid in the brain, and maybe even clear the brain of these plaques if the dose is high enough and patients stay on the drug for long enough. But we don't quite yet have sufficient evidence to feel confident that doing that is enough to produce a clinical benefit. And the reason for that is that though there are multiple clinical trials that very convincingly demonstrate this amyloid lowering effect of aducanumab, the clinical measures in those clinical trials were less convincing. There was an early trial that was very exciting, first to kind of demonstrate this amyloid lowering effect. It hinted that there might be a benefit clinically associated with doing that, but it was relatively small, certainly not of the size that we think of for demonstrating a clinical benefit. After that study, that early study, the sponsor of the maker of aducanumab, Biogen, launched two multinational parallel phase 3 registration trials that were both quite large and large enough to show a benefit clinically if one existed. Now, this is where the story gets very complicated and indeed controversial. Those two trials were both stopped early for what's called a futility analysis. So the company had a plan to peek at the data when a certain milestone was achieved. And in that peak, they decided that the trials were unlikely to demonstrate a benefit of aducanumab. And this was a very sad day for the field, for people in those trials, family members, and of course for Biogen. But the story wasn't done yet. And all of these things take time, and in the time it took to do that analysis, what we call an interim analysis, the data kept coming in. People were still participating in the trials. And Biogen would later announce that with further analyses and greater data that had been collected, they actually believed the drug was demonstrating a clinical benefit, and that they intended to submit those data to the FDA. So those data were submitted to the FDA, and there was an advisory panel convened. The data were looked at by various groups, even within the FDA, and it was complicated. There were two trials. They were more or less the same, although there were some important differences. But in the end, Biogen suggested that one of the trials was positive, meaning that people who got aducanumab seemed to do a little better compared to people who got placebo. And here, when we say do a little better, we mean get worse a little more slowly. This drug does not make people better. There's no improvement from taking aducanumab for people with Alzheimer's disease on our clinical cognitive assessments. But over time, we expect people to get worse, and it appeared that people who got aducanumab were getting worse more slowly. But in the other trial, that effect was not observed. And there are some abnormalities about these trials, and Biogen sort of made a case that if you looked at the right people in the other trial, you could see a similar benefit. But the evidentiary status that we really require for approval of a drug simply was not met. And so the advisory committee voted near unanimously to not approve aducanumab as a treatment. But as you note, on June 7th, the FDA actually did approve aducanumab, but they didn't provide a full approval. The approval was what's known as an accelerated approval. And so basically the FDA said, we're not convinced that aducanumab has a clinical benefit. We are, however, convinced that aducanumab can lower brain amyloid levels, and I am as well. Where there's more controversy, however, is the next step, which is the FDA decision to approve through the accelerated approval pathway indicated that lowering amyloid was reasonably likely to predict a clinical benefit. And this is where there's been great discussion, argument, debate in the field. Is lowering amyloid sufficient to conclude that a benefit will be received by people who take the drug and have their amyloid levels lowered? In the setting of clinical trials, we call amyloid in this case a surrogate outcome measure, meaning that it stands in for the traditional clinical measures of how someone's doing with their memory and thinking and ability to live life. And there's simply just not agreement about whether amyloid has been adequately demonstrated to predict clinical outcomes, i.e., whether it can be a surrogate outcome. And I personally don't think it has. It's I absolutely think amyloid is key. I still think it's a fantastic target for us in developing therapies. But I don't think we've yet shown that lowering amyloid is necessarily going to have a clinical benefit. And that's, what was so important about these Biogen trials and other trials like this is to give us answers to some of those questions. And unfortunately, I just don't think those questions have been answered yet. So that takes us up to June. And of course, now it's January of the next year, and more has happened. Most recently, so as of June, the drug was approved. That meant that Biogen could begin marketing the drug and doctors could begin prescribing it. But of course, that's not the whole story, and that's not the entirety of how medicine works in this country. So you've got an approved drug, you've got doctors who can prescribe it, you have patients who may want it, but another key thing is cost. And so as soon as the drug was approved, the sponsor Biogen announced an extremely high price for this drug, what amounted to $56,000 per year once a patient was up to the kind of standing dose that was anticipated to be needed for benefit. And I should also say that Aducanumab is a monoclonal antibody, an anti-amyloid monoclonal antibody. And what that means is that it directly targets the amyloid protein, but also it has to be injected into the blood. And that's how Aducanumab, that's the only way Aducanumab has been tested in human trials. So patients have to come in to an infusion center on a monthly basis to receive this drug. And given the initially announced cost, it was going to cost about $56,000 a year just for the drug. And that didn't take into account other things that were required, like confirming that a person had amyloid plaques in the brain. The FDA-approved label necessitated appropriately safety scans, which are MRI scans, to make sure that a person wasn't having an adverse reaction to the drug. So the total cost was sort of uncertain and estimated to be quite a bit higher than the $56,000 that it would cost to take the drug for a year. But the $56,000 on its own is extremely high, and certainly more than most families in America who have a loved one with Alzheimer's disease can afford. The company would later adjust the price, in part because of, seemingly, in part because of what was coming down the pike. And that was, are insurers and is Medicare going to be willing to pay for this drug? Because if no one will pay for it, it's going to really dramatically limit the number of people who could take it. Now, again, whether someone should want to take it, whether a doctor should want to prescribe it, is still debated. The evidence that the drug has a clinical benefit is right back where we were in June. There's no new evidence. We really have some positive data and some negative data, and I would say it's still uncertain whether this drug has a benefit. But it's approved. The FDA has approved it, so it's out there. Doctors can prescribe it. But last week, or the week before, I guess, on January 11th, a monumental decision was made by the Centers for Medicare and Medicaid Services. And basically, the CMS decided that they were only going to pay for Aducanumab in the setting of controlled research studies. And basically, they said that they were not going to pay for the drug in general. And this has been, again, kind of fueling the fire of debate in the field. Some people are arguing that this was the wrong decision, that this is going to really limit accessibility. That is true. That it could further widen health disparities in this country, because the poorest patients and the patients from specific low-income neighborhoods, particular cultural groups, are going to have essentially zero access, whereas the wealthy communities could afford this drug and will have access. That's also true. But we really still don't know if access is warranted. We really still don't know if this drug actually has a clinical benefit. And what CMS basically said was, we need to know that before we can cover this drug for everyone. And so they've outlined a variety of criteria that a study must fulfill in order for CMS to pay for the drug. And if those studies fulfill those criteria, CMS will pay for the drug in the study, as well as an amyloid PET scan to determine if someone is appropriate for the study, which is also one of their requirements. So it's been, to say the least, an eventful 18 months, I guess, now, dating back to the stopping of those trials, progressing through submission to the FDA and the FDA advisory committee meeting, ultimately an FDA decision, and now a CMS decision. It's been difficult. I don't mind saying. It's divided the field. There are strong opinions on both sides of these various debates. I think the last thing I'll say before I let you ask a second question, the last thing I'll say is that it's important to remember a handful of things throughout this. One, all of this represents tremendous progress. The fact that Aducanumab got as far as it did, as fast as it did, the fact that we have not one but multiple drugs that can actually lower amyloid levels in the brain, the fact that we have had our first FDA approval, but many of us have mixed feelings about it in more than 15 years. All of this does reflect the investment in Alzheimer's disease research by the National Institutes of Health and advocacy organizations, the commitment of investigators around the country and around the world to try to learn as quickly as possible and move us forward as much as possible. And of course, the incredible, unequaled investment and contribution that the people who have participated in our studies have made. And that goes for the people who are enrolled in the Aducanumab studies, as well as in the other monoclonal antibody studies that have been performed and are ongoing, as well as people who are in observational research studies that told us a lot about how these things develop in the brain, change in the brain, identify treatment targets in the brain. Without all of these various groups coming together over the last many decades, none of these controversies would have been possible. And so I think what's most important is that we get past this now, realign toward our common goal of finding not just treatments that can get approved, but that have no debate about them, have no controversy associated with them, that are very convincing in their ability to slow or stop this disease or reverse this disease. And there's lots of work left to do. Some of these changes, whatever side of the controversy you're on, may push us closer to answering different types of questions that we haven't been able to answer until now. So I'm an optimistic person by nature, and I remain optimistic. These controversies have been challenging, but it's time for the field to coalesce, move past these things, sort this out, and get back to work.
Absolutely. Okay, I want to go back to the CMS proposal for just a second.
Sure.
Has CMS made a decision like this previously for another drug where they only cover for people enrolled in clinical trials?
They have. I don't consider myself a Medicare historian, so I won't speak with too much authority. This is near unprecedented, but not totally unprecedented. And And of course, as an Alzheimer's disease researcher, I'm most aware of the previous CMS decision around covering amyloid PET imaging. So we have PET scans, positron emission tomography scans, which are brain scans taking pictures of the brain after injecting something into the blood to show us a specific protein, in this case, amyloid. And CMS several years ago made a decision that they were not going to cover those scans. So those scans are not as widely used as they would be if CMS covered them. CMS did agree to cover the cost of the scans in the setting of a research study, which was led by the Alzheimer's Association, the American College of Radiology, and our friend and colleague Gil Rabinovich from UC San Francisco. And that study was published a couple of years ago, and I thought very convincingly demonstrated the clinical utility of amyloid imaging. About 35% of people had their diagnosis changed. A greater percentage, close to 45%, if I remember correctly, had their medications adjusted, either stopping or starting Alzheimer's disease medications, the older symptomatic drugs that were available at the time. So, that was a very meaningful study. CMS, made that study possible, and there's still hope that, as these changes occur, amyloid PET imaging will become more available because many of us think it's valuable to families to have that information. So, this isn't exactly the same situation. A treatment drug is not the same as a diagnostic agent. It's much more difficult to do rigorous studies of treatments, namely that we tend to like placebo-controlled trials for eliminating sources of bias and answering the question definitively. It's difficult to imagine a CMS-funded placebo-controlled trial because there are some copays and the like associated with CMS, and no one should pay to take a placebo, and frankly, no one should pay to be in a trial. So I don't consider myself the authority on the history, but no, this is not a frequent occurrence, and I think it speaks to a number of things, including the importance of what we do. In anticipation of the decision by CMS, one arm of the agency, independent of the decision, had actually suggested that the premiums, the CMS Medicare premiums, needed to be increased in order to cover the potential cost of covering Aducanumab in the millions of Americans who have Alzheimer's disease. That has not played out the way it might have, and Secretary Becerras actually proposed that we should hold off on raising the premiums. I don't think we've heard in the last 2 weeks since that announcement what's gonna happen there, but I think it just goes to show the magnitude of importance that Alzheimer's disease represents for our national healthcare system. This is a disease that already affects 6 million Americans. The numbers are only going to go up as more and more people are living longer and longer lives. And so when drugs get approved, it has big ramifications. And of course, our goal as researchers is to have positive ramifications, that is, find ways to lower the burden associated with this disease for our nation, for every nation, and research is the path to doing that.
Good. What does the decision for Aducanumab mean for other candidate investigational drugs?
Yeah, this too is being debated a little bit because the CMS announcement did suggest that it was a class approach. So it was certainly the case for Aducanumab, the only currently approved monoclonal antibody against amyloid. But other drugs are in the process of applying for requesting that same accelerated approval. So I think, I don't know for sure, but I think it's safe to say that if another drug gets an accelerated approval, in the absence of resounding, convincing clinical benefit data, which you only get from a phase 3 registration trial. The decision would cover those drugs too. What I don't think we know yet is what if the phase 4 aducanumab study or the ongoing phase 3 trials of some of the other monoclonal antibodies are convincing. My assumption is that the thing CMS would reconsider in that setting. But we don't have a drug that has convincing clinical benefit data among any of those agents yet. So it's a guessing game. But I do hope that if, donanemab, lecanemab, or gantenerumab, some of the other monoclonal antibodies that do seem capable of lowering beta amyloid levels in the brain, and are still in trials that are meant to assess efficacy, clinical benefit, my hope is that they work convincingly, that there's no debate about it, and that it might adjust CMS's approach to coverage.
Mm-hmm. Now, has Biogen started their phase 4 confirmatory trial?
No, I don't believe they have begun the trial. I do think that they've made some announcements. I don't think we have a lot of information as yet, but the trial is planned to begin in 2022, and they are hoping to do it in far less than the 8 or 9 years that they sort of initially announced was their deadline. I've seen 4 years to try to complete the study, but we don't really know. I think the other thing that Biogen announced, and it gets to something else that was in the CMS decision that I haven't mentioned yet, was their commitment to trying to enroll a diverse population in the phase 4 study. And that too was a key aspect of the CMS decision, was that for CMS to cover the cost of a monoclonal antibody in the setting of a trial, that trial would have to accrue a representative population, representative of our nation's racial and ethnic diversity. And this is extremely important. It's been lauded by many, but others have acknowledged, we've never really done that. We've never enrolled to a large clinical trial for Alzheimer's disease and had a population that was actually representative of our nation. And there's lots of different ways that we could point out our lack of representation, but the most striking, and some would say the most important, is racial and ethnic diversity. So, achieving 13% participation rates among African American persons with Alzheimer's disease is a important goal and an important mandate from CMS, but it will be extremely difficult to achieve. We should absolutely strive for it, but it is not an easy thing to do. And of course, it goes for other groups as well. Asian Americans, Hispanics, all of these populations are very consistently underrepresented in our clinical trials, as well as in other types of studies. Now, of course, here at UCI Mind, we've had a long commitment to increasing representation of all of those groups. But to do this in a large national study, especially one that involves a burdensome and somewhat risky therapy, that's a whole new challenge. I say somewhat risky. I think the risk profile for these drugs is quite manageable by our expert clinician colleagues, but there are real risks associated with these drugs. Every drug has risks, so all of this factors into an individual's willingness to participate in a trial, whatever community they're from.
I think we have time for maybe one more question. Do you have a sense of how many doctors are prescribing aducanumab at this point?
So, I don't think we have great numbers. The numbers that are out there suggest that the uptake of prescribing the drug has been relatively low. And there are a number of reasons why that could be happening. Now, first and foremost, insurers aren't typically paying for it. So that's a massive barrier that is difficult for most patients in this country to overcome. A lot of hospital systems are not putting the drug on formulary, so it limits the ability of a doctor to write a prescription for aducanumab at this time. And there are the real controversies, and it's easy to imagine that this is a difficult drug to talk about for a doctor with their patient with Alzheimer's disease and their family members. It's a long story. I think my answer to your first question took 20 minutes. So doctors may not have time to go into that amount of depth. They're presenting a case that is muddy when it comes to clinical efficacy. They have to talk about safety. And there is a real safety profile that includes, swelling and bleeding in the brain. We think it's manageable, but these are scary terms: swelling and bleeding in the brain. And then you add in the burden of having an infusion every time you want to take a drug treatment. So monthly visits to an infusion center, along with all those MRIs to make sure that you're not having a negative reaction and know when to stop the drug. That's a lot. So it's a hard thing to talk about, and I think it's a hard thing for people to be excited about taking in the absence of really profound clinical benefit data. So we'll see what's going to happen. We'll see, what the final outcome. I should have said the CMS decision is not final. We're in a 30-day period for open comments on the Medicare website. I encourage all of our audience and community members to speak their minds. Your voices can and should be heard on important topics like this one. Hopefully the phase 3 trials, phase 4 trials will give us better data to make it easier to see these drugs enter practice. But until then, I suspect the prescribing rates are not going to go up a great deal.
All right. Thank you, Dr. Grill, for coming back on the program and updating us on Aducanumab.
You bet. Thanks for having me, Megan. Happy New Year to everyone.
Happy New Year to you. All right. And thank you to our audience and everyone who joined us. You can access this and past Ask the Doc episodes, podcasts, and more on our YouTube channel and on our website at mind.uci.edu/Mindcast. In the meantime, to learn more about research at UCI Mind, you can visit our website or consider signing up for UCI's Consent to Contact, c2c.uci.edu, to learn more about research studies that might be right for you. Take care, and we'll see you next time on Ask the Doc. Bye-bye.